Hello, Dr. Darty here with a short chat on Chapter 13, which is the urinary systems, kidneys, ureters, also bladder. Before we get started, I need to confess that I've actually been sleeping with a urologist for more than 40 years now. So next to pediatrics, this is probably the discipline in medicine that I have the broadest vocabulary in and understanding of. To start off with, let's clarify which ologist is which. This is a source of confusion, sometimes even among medical people. A urologist, like my husband, is a surgical specialist. They do some general surgery training and then do further training that takes several years in urologic surgery. They're often referred to by other physicians as the plumbers because they do serve sort of the same job in the human body that you might call a plumber for in your house. If a drain isn't working, if something's stopped up, if flow isn't going where it's supposed to or is going where it isn't supposed to, then you call in the plumber. So they are interventionists. They like to cut to cure, as they say. They also do a lot of things besides cutting, and they do a lot of studies to help determine what's wrong when something isn't working properly. But they are sometimes confused with nephrologist, Nephrologists. Nephrologists are specialists in diseases of the kidney. Their initial training after medical school is in internal medicine, and after studying that for a while, doing some residency there, they then do specializing in the diseases of the kidney. So obviously these two specialists often work hand in hand. Patients sometimes make an appointment for one when they really need to see the other. Urologists and nephrologists also work hand in hand with a lot of other specialists in the healthcare field, including in particular radiologists who provide the images that they're needed sometimes to elucidate what's going on in the urinary system. Also, with cancers, which are common in the urinary system, they work with oncologists, cancer specialists, and they work with radiation therapists, a special kind of radiologist who directs radiation therapy to an area. So there are a lot of overlap there for the various specialists in the urinary system. But the primary two are urology, a surgical specialist, and nephrology. Those are folks who have internal medicine background and are more concerned with the function of the kidney. That said, let's talk a little bit about kidneys. I think if your body's organs were having a fuss about who was the hardest working and most important, there'd be several good candidates, but I think if you did it like bracketology, it might come down to the liver and the kidney, both of which have a lot of jobs that they take care of involving several body systems, and do it in a remarkable fashion. Your kidneys filter about 200 liters. Now you think what a 2-liter bottle looks like. 200 liters of blood every single day. So picture 100 2-liter soda bottles lined up all full of blood, gruesome thought, and say, okay, you got to purify all this. That's what your kidneys do for you every day. Each one is about the size of a bar of soap, and they sit extraperitoneally behind the peritoneum, the bag that encloses most of your digestive tract. So they sit in what we call your flank or the CVA area, the costovertebral angle. They sit where your lower ribs and your spine come together. So they're dorsal organs in a way. They're in your back, which explains sometimes when someone, say, has a kidney stone, they experience that as flank or back pain initially. It's a very nice drawing on page 352 of your text or e-text that shows you the urinary system and shows you the kidneys, which have tubes leading from them down to the bladder. The tubes are called ureters, and you have one on each side, and then you see the bladder sitting low in the pelvis, the urinary bladder. So those are the main organs. Now your book goes into a very skimpy detail, and that's really all we need for this course, on page 352 about the inner workings of the kidney. They even have a nice diagram for you of a nephron, the functional microscopic unit of a kidney. You might think of a nephron as being a little bit like an espresso machine. It's a special little ball of capillaries called a glomerulus, hard to say, hard to spell, glomerulus, that are under very high pressure. So they push the plasma, excluding the protein, through there, and the holes, if you will, in this filter. It's a really elaborate construction. And that substance that's pushed out into the tubule, and you can see the picture of the tubule there. Again, this is microscopic on page 352, figure 3.3. That filtrate, after it's changed as it passes through that long tube that looks sort of like a paper clip, after it passes through that tube, it becomes urine, which is then transferred via the ureter down to the bladder and eventually into the toilet. So it seems like a simple system, but it's really pretty complex and it's fascinating. One of the strange things in physiology is the way your kidney filters things is a bit like when you clean out a super messy junk drawer or closet, you just throw everything out on the floor and then you decide, oh wait, I really need that screwdriver, I need those Post-it notes, whatever, that you're going to put back in your junk drawer or your closet. So it throws everything out, or a lot of things, that it really intends to keep, like sugar, amino acids from the steak dinner you had last night, calcium from the milk or yogurt that you had that you need for your bones, sodium that you have to have, potassium, a lot of things that get pushed out in the initial filtrate. It's as though your kidney says, oh no, wait, we don't put that in the toilet, we'll take that back. Now, if you think that sounds like an interesting story, and I promise it is, you really should take A&P where they will beat it into you for the better part of a week. It's really an interesting topic. But beyond our scope to go into all that today. So we'll talk about some of the words here that you see in the first table there on page 353. We've said several of them already. One we did not mention was the hilum of the kidney. Again, if you refer to the previous page and you see where the blood vessels enter the kidney and the ureter leaves the kidney, that little area right there is called the hilum. Nitrogenous. Nitrogenous is perhaps the most important waste that is filtered by the kidney. Your body's metabolism is always ending up with these leftover ends of the protein that have nitrogen in them, hence the name nitrogenous. And if they build up, they're very toxic to your body. So the substance that it's in, some packaged in, if you will, in a molecular level, is urea. You see where we get some of these words all tied together. So when you smell a diaper that's been left too long, perhaps in the wastebasket or an old-fashioned cloth diaper, you know how it has that ammonia smell? Well, ammonia, as you know, is a nitrogen-containing compound. So your body can't get rid of nitrogen effectively in any other way except through the urine. You get rid of a bunch of other stuff that way too, but it's absolutely vital that the nitrogen, the urea in your blood, gets taken care of by your kidneys. One of the tests that you lab folks are aware of is BUN, blood urea nitrogen, which gives us an idea of how your kidneys are functioning. Another one you may know about is creatinine, not to be confused with the creatine that's sold in powder at health food stores. Creatinine is itself a harmless byproduct of protein metabolism, but it's a very good marker in the lab for how effectively your kidneys are working, how well they're filtering stuff out. So you will hear a lot about creatinine, creatinine clearance. Those are all tests that give physicians a really good idea of how your kidneys are functioning. Those are the most important words on that page, I think. On the next page, we see quite a few that you will hear frequently. One of them is hematuria. And just like you know that hemoglobin is the blood protein that carries oxygen, when we hear that heme, that's sort of a clue that we're talking about blood. So hematuria is blood in the urine. And it can either be gross hematuria, where it's like, oh boy, my urine turned red, that's not good. Or it can be microscopic hematuria, where it's only picked up by looking under the microscope or using a dipstick, a urine dipstick. The urine looks fine, but when you test it, it turns out there are some red blood cells that shouldn't be in there. That's hematuria. Now, there's a real tongue twister, glomerulonephritis. I know that sounds like a lot, but that is an inflammation of the microscopic structures in the kidney. It can happen for a lot of different reasons. A common one is post-streptococcal glomerulonephritis, where an untreated strep throat causes inflammation in the kidney, but there are many other causes. Toxic drugs can do it. A lot of things can give you glomerulonephritis. And it can result in long-term kidney damage, or it can be resolved and the kidney can be fine afterwards. Wilms tumor is a tumor found primarily in children that originates in the kidney. And if you watch the commercials on TV for St. Jude and some of those other places that treat children with cancers, you will hear about Wilms tumors. Nephrotic syndrome, you can think of that as a leaky kidney. It's where protein that should not appear in the urine suddenly starts appearing in the urine. And because of that, the body can't hold water within its blood vessels like it should, because protein helps with that. Again, take A&P, they'll teach you all about it. But nephrotic syndrome often causes patients to become edematous, meaning swollen, because the fluid that should be in their blood capillaries leaks out into the surrounding tissue. Also is often accompanied by high blood pressure, so nephrotic syndrome. Pilogram, and you will hear that most often as part of the words that are abbreviated IVP. IVP stands for intravenous pyelogram. Get an IVP on this person. You'll hear in orders we need to get an IVP. Well, intravenous pyelogram means dye is injected into a vein, the patient's vein, and as it's excreted through the urinary system, you can see it light up the structures, the collecting structures in the kidney and down through the ureter. So that's an IVP or pyelogram. A diuretic, I'll bet you knew this already, is a drug that encourages, enhances, amplifies urine production. Your grandma might have called it her water pill. You may know Lasix is a common diuretic. That's the most important words on that page, I believe. Moving along, on page 357, we see the word anuria. Anuria means not making any urine, which is obviously bad for the reasons we've already discussed. For those of you who are working in ICUs and have patients who are catheterized, we really check in the catheter to see how much urine is being formed on a regular basis, hourly, frequently, because that's an overall indication of how well the kidneys are filtering. Lets us know, are they getting enough blood? Has something happened to damage them? An ominous sign in a severely ill patient is if they stop making urine. That's called anuria. Dialysis is what we do when someone's kidneys are not functioning well enough to sustain life or a good quality of life. So you may know someone who is on dialysis. It can be either done through a shunt, typically placed in the arm initially, where they can hook the dialysis machine's tubing directly into the patient's circulation. That's what we call, a dialysis center. That's what's done. Or peritoneal dialysis, and they have a picture of that on page 356. Patients sometimes actually have a catheter inserted into their abdomen, into their peritoneal cavity, and a solution is inserted that sort of acts as a very poor form of renal function. It helps to absorb from their system some of the toxins that the kidney should be eliminating. So the fluid is put in, it absorbs some of the bad stuff, and then it is removed. And some patients do quite well for a long time, especially those who have some residual renal function. If all renal function's gone, they typically need hemodialysis, the kind you think of probably as dialysis with a dialysis machine in a dialysis center. Oliguria is what happens right before anuria. That means not enough urine. And you may have experienced oliguria yourself if you worked outside or exercised on a hot day and didn't drink enough, and you realize, oh my gosh, I haven't peed for 5 or 6 hours, and you go in and it's very dark yellow urine and not much of it. That would be oliguria. Then they talk again about different kinds of kidney disease, including polycystic disease. A fairly common condition, it's typically genetic, and these patients develop renal failure over a period often of years and may end up needing, what's also on this page, a kidney transplant from a living donor or cadaver donor. Those patients who are fortunate enough to receive a living donor kidney typically do better than those from a cadaver donor, but it's a life-changing thing. If you know someone who's been on dialysis for a long time, it's a restrictive sort of lifestyle, both in terms of time, but also they have to restrict what they eat, what they drink. It's a difficult situation over the long haul. So these folks are typically delighted if they can receive a functioning kidney transplant. Moving on, if you look on page 358, there's a nice little schematic, not to scale obviously, of a very large kidney with the tube called the ureter leading down to the bladder. You can think of a ureter as being almost like an esophagus, only from the kidney to the bladder instead of the throat to the stomach. It's a very thin tube that has smooth muscle in it that contracts with that same peristalsis, boa constrictor type activity to push urine from the kidney to the bladder. And that bit of urine that it's squeezing downward is called a bolus of urine, just as we had a bolus in the esophagus. This is why even if you stood on your head or hung for your heels all day long, you would eventually get a full bladder and need to pee. So gravity obviously helps with pulling urine from your kidney to your bladder, but the smooth muscle of the ureter does most of the work. Now, it doesn't like to be stopped up. Most things in the body that are supposed to move something from one place to another let you know in a hurry if that's not happening, and the kidney is a real good example of that. Some people develop kidney stones in their kidney. They collect up there in that hilum, in the renal pelvis, the part that looks like a funnel. And they may sit there for a long time and not cause any problems at all. But if they start to move into the ureter and block it, they cause excruciating pain, often accompanied by nausea and vomiting. Patients can't get comfortable. I haven't experienced it, but those who have say it's the worst pain ever. So if a kidney stone gets stuck there, then that sometimes, not always, requires intervention. Certainly often requires pain medication. Many stones, small ones, pass on their own. It's not any fun. Larger stones may have to be retrieved through a ureteroscope that is threaded up through the bladder into the ureter, and they have little baskets they can grab it with. Rarely they will have to actually go in and cut the stone out. That doesn't really happen very often. The stones are called, as your book points out, renal calculi. One is a calculus, and the condition while they're in your kidney is called nephrolithiasis. That means stones in the kidney. When you hear that lith word, that root, that means that it's a stone. You might know the word monolith, like monolithic. It means a stone, or Paleolithic, that's the Stone Age. So lith means stone. Which leads us to another word that we will encounter here in a minute, lithotripsy. That's where sound waves are used to break the stone into fragments that can, we hope, be more easily passed in the kidney stone that's stuck. So it's the main thing that happens in ureters. You can also have cancers that develop in the ureter itself. So now we're down to the bladder, the urinary bladder, which is basically just would remind you of those shopping bags that you can fold up and then unfold when you need them. It's a smooth muscular bag that can inflate to hold quite a bit of urine, but then obviously it's a relief when we can decompress it out through the urethra. For women, the urethra is very short, from the neck, the bottom of the bladder, out to the external part of the body. For men, it's much longer, goes through the penis to get to the outside. So that's one reason why women are more likely to get urinary tract infections, which we call UTIs, than men, because it's a very short hop from the bottom of the body, where the poop also leaves, up into the bladder, than it is for a woman than it is to go all the way up through the penis. That doesn't mean men can't have UTIs. They definitely can. So you see on page 359, you see some of these words we've already talked about. Calculus, the kidney stone, calculi plural. A dipstick, you've seen those at the doctor's office. It's the little strip of paper that has multiple colored squares that tells us a whole lot about the urine in a very short period of time. Extracorporeal means outside the body. So that's extracorporeal shock wave lithotripsy. That's ESWL. That's the treatment where you use sound waves to treat a kidney stone. Hydronephrosis is a pretty common problem that we run into for a lot of different reasons. If a ureter is blocked off and the urine can't get down into the bladder, it backs up into the kidney and can sort of cause the kidney to balloon up. It can happen prenatally. It happens sometimes in women while they're pregnant because the expanding uterus causes a partial blockage of the kidney. It can happen as a mishap during surgery. So a lot of different causes for hydronephrosis. It's where urine backs up into the kidney and causes it to swell. Moving on, there are a lot of words they want us to know. Page 361 has some more of these words. Some of them we've already said and you may know. One is enuresis, that is urinary incontinence. It typically means bedwetting, but it can happen at other times as well. Enuresis. Meatus is the opening at the tip of the penis or in the bottom of a woman's body where the urethra opens to the external part of the body. Micturition is the act of voiding, just like mastications, chewing, deglutition, swallowing. Well, the real name for peeing, or whatever other words you want to use, I know a lot of them, is micturition. A sphincter, we talked about that in the GI tract, is a cuff, if you will, a circle of muscle that allows us, if it's a voluntary sphincter, to be potty trained so that you don't pee your pants all the time. So we have an external urinary sphincter that controls our ability to hold urine and to be continent. Urethra, we talked about. Don't mix up ureters and urethras. Ureters are kidney to bladder. Urethra is bladder to the outside of the body. Voiding, we know what that is. Voluntary and involuntary. All right, a lot of words. Page 363 has some more words they'd like for you to know. Cystitis means a bladder infection. Very often lay people will say, oh, I had a terrible kidney infection last week. Almost always they didn't have a kidney infection. They had a bladder infection, or we just say a UTI, urinary tract infection. True kidney infections, pyelonephritis, is a much more serious situation. Patients typically have fevers. They are systemically ill. They have nausea. They can't get out of bed. They can get the infection in their bloodstream from pyelonephritis. So it's a real 4-alarm fire. Cystitis can feel like a 4-alarm fire, but typically it's less threatening to somebody's overall health, although it's very uncomfortable. It causes dysuria. That's the next word. If it hurts to pee, that's called dysuria. D-Y-S, not D-I-S. We know what incontinence is. Pyelonephritis we just talked about. Retention is another problem urologists frequently see, especially in men. We'll talk about the prostate gland in our next chapter. And the prostate gland encircles the male urethra as the urine leaves the bladder to go to the outside. And under the influence of the male hormone, it can keep growing throughout life to where it finally sort of strangles the urethra. And then men can't pee. Or they can't pee effectively. They may empty some urine, dribble, but can't really void to completely empty their bladder. And if they eventually can't pee at all, that's a pretty emergent situation called retention. It can happen as a complication of other things like spinal cord injuries, or occasionally as a complication of anesthesia. So retention means I need to pee, but I can't. Suprapubic is the area right above the pubic bone, and if you stick a tube or a needle in that area, you can evacuate or empty the bladder artificially. So someone who chronically can't empty their bladder sometimes needs a suprapubic tube. If on a newborn we need a sample of their urine because we're worried about infection, we sometimes do a suprapubic stick where we get some urine out of the baby's bladder with a needle. Sounds terrible. Vesicoureteral reflux, which is often just called reflux in urologic circles, is where instead of all the urine going out of the bladder, out of the body toward the toilet or the diaper, whatever it's going into, some of it splashes or refluxes back up into the ureter. That's a bad situation, especially if it refluxes all the way to the level of the kidney where it can cause kidney damage. So that's vesicoureteral reflux. Vesico is bladder. Ureteral means in the ureter, and reflux means going the wrong way. Are we ever going to finish this? Let's see. Page 365 has a few more words you need to know. Not all of them, but to look into someone's bladder, the instrument is a cystoscope, and the procedure is called a cystoscopy, typically performed as an outpatient. Glycosuria is sugar in the urine. Diabetics spill, we use that expression a lot, so much sugar, so much is filtered out that the kidney can't reclaim it all. And so they end up with sugar on that dipstick when we test it. Nitrites are another substance that you see in the urine sometimes with a urinary tract infection. The bacteria work on the nitrogenous waste that's supposed to be in the urine and form chemicals called nitrites. So it's another way that we know on a dipstick that there's a good chance a patient has a UTI or urinary tract infection. Moving on, catheters, I'll bet you know what those are. That's an artificial tube placed into a bladder, typically drains into a bag. If it's used long term, if we're using it just to obtain a specimen, we get some in the cup, close it up, take the catheter out. We talked about dialysis. We talked about lithotripsy. Nice big word, nephrolithotomy. That's where you do surgery to remove a kidney stone. Ureteroscopes we talked about. Page 369, I don't see anything there that's pertinent to what we need to know. I think that's probably enough words for one day, more than enough words for one day. But the urinary system, even though we don't think about it unless there's a problem like a stone or infection, it just quietly does its job, is really important to us, and it's an interesting system to study. So thanks for listening.